Hello and welcome to our Infectious Disease podcast. Today's episode is the third in a three-part series on overcoming barriers to optimizing ART for people living with HIV. We're joined by Dr. Dima Dandachi from University of Missouri and Professor Chloe Orkin from Queen Mary University of London. To follow along with the slides, visit the show notes for this episode. Now let's join the discussion with Dr. Dandachi.
Yeah, so we're going to discuss how fear of virologic failure can create barriers for people living with HIV to access antiretroviral therapy regimens that may be a better fit for their individual treatment needs and preferences. So really the question is about why still this idea exists about don't rock the boat, right, for our patients. And I think about switching when we switch antiretroviral therapy in people who are already suppressed. I think the most important concern that we have is that the virologic failure. Some of us were trained in a time where never change a suppressive regimen because of memory of older probably regimens with low barrier to resistance and subsequently high resistant risk. So virologic failure fear become like a reflexive barriers. But I often ask my ID fellows, how many times have you really heard this sentence saying, but what if they fail, as the reason not to change? And today we want to challenge that reflex. The next question people ask is that why even switch, right? And there are so many benefits beyond staying suppressed: tolerability, convenience, quality of life, less drug-drug interaction, reducing stigma in some of the situation. So we have to adopt a really more proactive approach. What do you think, Chloe?
Yeah, I really agree that we have to bear in mind that the evidence shows a very low risk of virological failure, and we need to think of a person as a whole person. And if we look at the randomized clinical trial and also the real world study data, it's really consistent that it shows that there's low virological failure rates when people switch to two-drug treatments, especially D2D3C, to two-drug injectables, cabotegravir, rilpivirine, and of course to second-generation integrase-based three-drug oral therapies. So how about we start by discussing real-world data on two-drug switches? So if we think about the efficacy of switching to two-drug oral therapy and look at the real-world evidence, there's a systematic literature review which included nearly 13,000 people who switched to D2D3C, showing switch successfully with suppression. So moving forward to thinking about cabotegravir, rilpivirine, I mean, what do you think about that, Dima?
Yeah, I mean, you mentioned kind of like the switch to oral to drug regimen, but also it's the same true for long-acting injectable therapy with two-drug cabotegravir and rilpivirine. So this study, it brings together multiple real-world cohorts evaluating long-acting cab and rilpivirine switches across diverse settings and countries. You see, there are 3 that were done in the US and multiple done in European countries. But if you see the virologic failure across all these studies, real world data, like it's between 0.4%, and actually in the Beyond study, we were part of this study as well, to 2.4%. So this is kind of like the average that we saw actually in clinical trials as well. And taking together, really all of it together, this data highlight that in practice, switching suppressed patients to injectable cab and rilpivirine in durable viral control results in durable viral control and rare failure events across diverse population and healthcare system.
Yeah, I completely agree with you. I mean, the one comment I would make is just that some of the follow-up is sort of shorter than others, but we are starting to see longevity of data, which is really great to see. And I don't know if you had any other points that you thought of in terms of, all of that data.
Right. And we want to emphasize that despite that over rates of virologic failure is low, that doesn't mean that patient selection doesn't matter. So I want to ask you about the studies that you have done about what are the risks for failure in people who are started on long injectable Cabenuva and rilpivirine, and how we would select the best patients for that.
Yeah. So I think one of the things that we need to do is we need to be evidence-based. And that's why I led a large multivariable analysis to try and identify the factors associated with biological failure to help clinicians to select people appropriately to even further reduce the risk. So a multivariable analysis that we did based on the FLAIR study, the ATLAS study, and the ATLAS 2M study in 1,651 participants from these 3 registrational trials identified 3 baseline risk factors. And they are archived rilpivirine on proviral DNA, which was done retrospectively, the HIV subtype A6/A1, and the BMI greater than 30. And what you see is the overall risk was 1.4% of virological failure. If you had no factors, the risk was 0.4. If you had one factor, it was 2%. And if you had greater than two factors, it was 19%. It's important to say that when I say one factor, I mean the A6A1 or the rilpivirine RAMs. When you look at BMI alone, it's not a significant factor of that order of magnitude. The order of magnitude is about 0.5%. So thinking about that, the way I would sum that up is to say that although the virological failure rate is low when you switch to cabotegravir or rilpivirine, the risk of drug resistance at virological failure is not negligible, okay? But the resuppression rates are high with the regimen change. And I think what would be helpful to talk about is further work that we've done since then, which is really looking at what happens in clinical practice. So what we did is we recently published this in the last couple of months. We did a very large systematic review of switching to cabotegravir or rilpivirine in observational cohort studies. And we looked across cohorts in any language, and we looked across 79 cohorts, and we found the virological failure rate to be 1.2% out of nearly 14,000 people. And not all of those people who were reported had accompanying data on genotypic resistance. So not all of the cohorts even described this. But where they did, there were 80 cases of VF, which also described what happened with resistance. And what they showed is that about half the cases NNRTI resistance was present, just under half, around half were in INSTI resistance. And then there was some dual class resistance in 33 people out of 80, and no resistance in 28 people. So essentially the virological suppression rate, which is also really, really important, was close to 90%, and a range of regimens were used, including free drug integrase inhibitor-based regimens. And if you're interested in that, please do feel free to read the paper. So Dima, I don't know what your reaction is to all that.
Yeah, so I think like here, it just gives us more confidence and reassurance that these kind of the type of patients that might look like our patients who comes to clinic, you might not have like the baseline data for, all of them. But we do also, like this is talking about, we talked about like the switch to two-drug oral regimen, the two-drug injectable regimen, but also we have a lots of data over many years supporting the high efficacy and high barrier to resistance for second-generation INSTI-based regimen, three-drug oral antiretroviral therapy. So there is a lot of accumulating data that led actually to the FDA label expansion for Biktarvy just in July to include the treatment experienced adults with HIV who are not virologically suppressed, as long as they don't have like no resistance to the components of Biktarvy. So let's look at some of the recent data also from real-world OPERA cohort that we have evaluating these switches alongside the two-drug oral antiretroviral therapy. So if we see here, digging a little deeper into the real-world data from the OPERA cohort, and for those who are not familiar with OPERA cohort, it includes really routine clinical data from EMR of 84 clinics across the US and Puerto Rico. And it has like almost 14% of people living with HIV in the US. So they included in this analysis adults that are 18 and older and people with HIV who are virologically suppressed. And they switched to single tablet regimen, either two-drug regimen, dolutegravir, lamivudine, or the three-drug regimen, bictegravir, emtricitabine, and tenofovir, which would be Biktarvy, and a three-drug regimen, dolutegravir based. And this was from 2019 to 2020, and there were like 8,000 people that were included. And if we look at the overall virologic failure, we're talking like 88 people actually with HIV actually had confirmed virologic failure. So that's only 1%. Like regardless of what regimen really you switch to from the newer generation INSTI, like the risk of failure has been low across groups. If we compare the regimens, there was no statistical difference between the two-drug regimen dolutegravir, lamivudine, and the three-drug regimen Biktarvy. The group that has the highest confirmed virologic failure were in the dolutegravir three-drug regimen. And probably the explanation of that is that we're starting with a little bit different group here. Remember, this is real-world data. This is not randomized. So there might be some differences in the baseline characteristics of these groups, making like the decision and bias to choose the three-drug regimen with dolutegravir base. So next, you see that all of them really were followed, though, like for at least a year. And you see that the second outcome was regimen discontinuation in the study. You see a high number of, discontinuation in all groups. But most of the time, when the reason has been noted, it's not treatment related. So they classify that as not treatment related if it's like maybe an access issue, maybe provider decision, patient decision, but it wasn't related to failure and treatment related. So going on, so what do you think, like, Chloe, about this data comparing like these different regimens?
So these data show the important point that the main cause of treatment failure is not related to the viral efficacy of the regimen. And non-efficacy reasons that were cited in these studies included regimen simplification, access challenges, non-adherence, treatment gap, and also patient or provider choice. So I think switches do allow you to address some of these other regimen-related issues, which can in fact reduce the risk of virological failure. Dima, I don't know if you wanted to comment on.
Yeah, this is exactly what we see in our also like a practice among our patients, that when patients have actually like had virologic failure on a certain regimen, most of the time it's not related to the viral efficacy of the regimen itself, and it's related to factors related to adherence, to social determinants of health, of other factors that could affect patient adherence and maintaining on this regimen, or if they're not satisfied with the regimen. So like satisfaction with the regimen is like also an important factor. And as you said, probably switching to another regimen can allow to address these issues, and probably you would have less risk of resistance and failure. So, and kind of like the one of the study that was very interesting is the Impala study. So I don't know if you would like to kind of discuss that about people who had suboptimal engagement in care and treatment.
Yeah, thanks for introducing that. And I think it was a very, very interesting study presented at IAS that was in sub-Saharan Africa, Kenya, Uganda, and South Africa in people who had had viral loads greater than 1,000 in the prior 2 years, despite taking treatment, or history of loss of engagement with care for more than 4 weeks, or people had been unlinked to care for more than 3 months since their diagnosis, but they couldn't have been receiving second lines. There couldn't be virological failure to these regimens. So what happened is they were on 2 NRTIs plus dolutegravir, and they had to have viral loads less than 200 at screening for at least 3 months at the end of the screening phase. Okay, so by the end of the screening phase, they had to be having viral loads less than 200. And they were then randomized open label to cabotegravir rilpivirine 2 monthly versus 2 NRTIs plus DTG. What you can see is that there was non-inferiority for the two options, oral versus injectable, regarding the primary endpoints of achieving a viral load less than 50 by week 48, and also secondary endpoint viral load greater than 50. But what was really, really interesting is they added the sensitivity analysis of looking if people had a viral load greater than 1,000. Okay, the time spent with a viral load greater than 1,000. And here you can actually see that, in fact, there was superiority for cabotegravir rilpivirine in this particular analysis, because their hypothesis was that sometimes when people stop taking oral therapy, they have a period of time with a detectable viral load at a high level above 1,000, where they could actually potentially pass HIV on to others or experience, adverse consequences of having this. So they looked at this, which is a very interesting analysis in this population. And I thought was a really great sensitivity analysis to include. So Dima, I'm not sure what your thoughts are about that, and also about any other sort of specific.
Yeah, so when we are thinking about switching to other regimens, I think practically we have to keep in mind, like in general, what are the things that we would benefit from a regimen? What are the pros and cons, and what we have to keep in mind? So, for example, when we're switching to the dolutegravir lamivudine single tablet regimen, you're avoiding tenofovir. You have a drug with a very high viral efficacy proven in clinical trials and real world data. Less drugs, less drug-drug interaction, but think that you cannot use it with someone who have a chronic hepatitis B, right? For the bictegravir, tenofovir, decitabine single tablet regimen, this is a drug that's had very high genetic barrier of resistance and also active against hepatitis B. So that's kind of something to keep in mind. And when we're switching to long-acting cap and rilpivirine, really many people, and we see it in our practice, we see it in clinical trials and real world data again and again, many people appreciate the fact that they don't need to take a pill every day. The stigma, the anxiety of missing pills, it's a game changer for many of our patients. So also you'll be avoiding the use of tenofovir if that's something that you want to consider in your patient. The confirmed virologic failure is low, but probably they have a lower barrier to drug resistance compared to dolutegravir and bictegravir, and not active against hepatitis B as well. So you have to keep that in mind. So this is more like a practical points. We now have many options to treat people with HIV that are powerful and flexible, but the real challenge is making sure that everyone can access them. So that means like not acting as a gatekeeper, breaking down these barriers and giving people choice and voice and deciding about their care and what fits them. So what do you think, like, Chloe, about that and having this shared decision making with the patient?
Yeah, I mean, I think you've really, choice and voice is a beautiful way of describing it. And I think shared decision making is vital. And I think discussing it, raising these options, having optimization discussions every year with your patient is extremely important. And that means introducing the choices, particularly for those that may not know about these choices. So I think that's very important, and explaining the key qualities, as you said. I also think that we've seen in PrEP that having choice options, people being able to switch backwards and forwards and change their choices, is really important. And we did see at IS also the volition study, which was looking at people who was rapidly suppressed in dolutegravir 3TC, who then had a choice to go on to cabotegravir or rilpivirine or continue their dolutegravir 3TC. And I think that sort of study is very interesting. But really, it's up to the patient, as a person living with HIV, to decide what fits best for them at that time point in their lives, and that treatment is not one size fits all, and a treatment that's for one period of time may not be for a different period of time in the future.
That many people kind of wait until the patient brings up like the topic of changing the regimen or having issues with the regimen. And I think that's not a great approach to not have like a proactive. And there was a very interesting study that was published by Akoli et al. That's about shared decision making and its association with favorable health outcome. So they really surveyed more than 2,000 people living with HIV from 25 countries. 10% of the participants felt that their HIV medication limited their life, but did not discuss their concern with the provider. They mentioned top reasons as the perception that nothing could be done, or the provider never brought it up, or not wanting to appear difficult. So really, to continue to identify and address these unmet treatment needs, we need to ensure that there are ongoing open dialogue, discussing this risk and benefit, not waiting until an ad comes up on TV so the patient will bring it up. I think that's very important to keep that in mind. And at the end, if you don't remember anything from this presentation, the key takeaway is that switching does not inherently put patients at risk for failure. Instead, it can actually be opportunities to improve tolerability, convenience, and quality of care that will improve adherence and reduce the risk, basically, of resistance and failure.
So I would say that's all for today, folks. It's been a real pleasure to be here with you, Dima, and to have this really interesting discussion. Thanks to the audience for joining us, and I hope that you found it helpful for your clinical practice.
Thanks to our faculty, and many thanks to you, our listeners. To learn more about how to overcome barriers to ART, click on the link in the show notes. And to get access to all of our new podcasts, subscribe to our channel on your favorite player. Thanks, and we'll see you on the next podcast soon.